Hi, Colin.
Hi, it's Clark. So, are we back in a court situation?
Yes, Chair, we've got four members present, so we can go ahead with the evidence session, okay? We only require four
Okay.
for quorum. We don't need five until decisions are made, so we can go ahead with the evidence session.
Okay. So, members, we're now moving on to item 7 in terms of our consideration of the Severe Fatal Impairment Abortion Amendment Bill. We're receiving today a briefing from Down's Syndrome Research Foundation and Don't Screen Us Out. It's the third of today's briefings on this bill, and I can advise that representatives of both organisations are present to give evidence today. I'd like to refer members to a copy of the written submissions from Down Syndrome Research Foundation at tab 8.1 of the pack, and to the written submission from Don't Screen Us Out at tab 8.2. I would also like to apologise to both Elizabeth and Lynn for the delay in the meeting. We had to suspend today's meeting and return following the unscheduled plenary session of the Assembly. But so I appreciate your coming back to us at this point, both of you. So I would now like to just welcome Dr. Elizabeth Corcoran, who is Chair of Trustees in the Down Syndrome Research Foundation. Can you hear me okay, Dr. Corcoran?
I can, Chair.
Thank you. And Miss Lynn Murray from Don't Screen Us Out. Can you hear me okay, Lynn?
I can hear you. Can you hear me?
Yes, I can hear you there, Lynn, indeed. If I could just advise all members and... Yeah, go ahead, Lynn.
I was just going to say I had problems getting in on my laptop, so I'm on my phone, so I was just checking that you could hear me okay.
Okay, we can hear you. It's a little bit low in volume, so if you just speak as loudly as possible, Lynn, but we are hearing you okay. So listen, I just want to also advise all members of the panel and members attending that it's better if people have access to a headset. It's usually better sound quality, and if people can ensure that they're on mute when they're not contributing, that also helps greatly with the sound quality. So we are now resuming our meeting in live session. I'll welcome you both. And if I go back maybe to yourself, Dr. Corcoran, in terms of maybe could each of you give us a brief 5-minute presentation, and then we go to members' questions, if that's okay.
Yep. Right. So thank you for inviting me to speak here today, Mr. Chairman and Health Committee. To give you some background, a dearth of research around Down syndrome has led to a parent initiative to establish the Down Syndrome Research Foundation back in 1989 with an aim to improve the health outcomes for people with Down syndrome. So I speak to you today as the chair of the Down Syndrome Research Foundation. That's a role which I've held over well over 10 years. I haven't counted. I'm also a doctor, a psychiatrist by background. So over the years, it's been a challenge for my charity to fund and establish research projects in the UK and indeed worldwide due to a prenatal screening program and high termination rates that have mostly resulted in terminations of pregnancies. In fact, the recent research found that people with Down syndrome die 28 years before those who do not have the condition, accentuating the urgent need for more high-quality research, as many of these deaths in the learning disabled community are avoidable. And in fact, the LEADER report was just released. Survival rates for people with Down syndrome have indeed improved also, mainly thanks to better inclusion in mainstream society, freedom from institutions where they were dying at a young age, and opportunities that being in the community affords them in terms of general health care. However, even in the 1990s, people with Down syndrome were still not being offered health care that they needed, such as life-saving heart operations. But hard-fought victories have been achieved, and even babies with Down syndrome who require heart surgery can expect to be offered it and are successful over 90% of the time. Unfortunately, we know from a recent Freedom of Information request that only about £5 per person with Down syndrome per year is spent on treatment and intervention studies. And in comparison, we know from this Freedom of Information request that between the 2010 and 2018, NIHR and MRC spent $5.4 million on improving the screening program, and indeed, NHS spends over $30 million every year on antenatal screening. So hence the 40,000 people living with Down syndrome in the UK still have to deal with something called diagnostic overshadowing and a lack of focused health screening and specialized treatment. The routine offer of screening has not led to any therapeutic benefits for the Down syndrome community, even down to even enhanced counseling or care pathways for expectant mothers. They still largely do not exist. In maternity care, women's decisions are questioned repeatedly after it is found the baby has Down syndrome. We were involved with the development of a publication of a report which confirms that many women are subject to subtle and not so subtle pressure to terminate their pregnancies. And this issue has been reiterated by RCOG as a part of a recent statement around the care of women who are offered screening. Whilst choice to terminate is based on disability may appear to be available to be helpful for women, disability abortion has a more worrying aspect to it, as observed in a statement by the Royal College of Obstetricians and Gynecologists. When they were being questioned by the UK Screening Committee on their decision not to provide the new NIPT test, they said, quote, "If the decision has been made primarily on cost grounds, then a more rigorous economic analysis has to be made that includes the lifetime costs of caring for children and adults with Down syndrome." In the years following the 1990 HFEA clause, which allowed abortion up to birth in the case of disability, there has been notable comment made on this matter. The Disability Rights Commission, now the Human Rights Commission, made it clear that this clause reinforces negative stereotypes of disability and is incompatible with valuing disability and non-disability equally. In 2017, the UN Committee for the Rights of the Persons with Disabilities in the UK and Great Britain and Northern Ireland recommended that abortion law be amended to stop the legalization of selective abortion on the grounds of fetal deficiency. Disability Rights UK charity also made comment on this clause. Their CEO said, quote, "Fundamentally, it is about equality. Wherever Parliament sets the number of weeks after which an abortion is not permitted, it should be exactly the same whether the pregnancy is likely to result in a disabled or a non-disabled child. All lives are equal," unquote. We are in full support of Paul Given's Severe Fetal Impairment Abortion Amendment Bill, as this is a time in the UK where, as a society, we have come to understand that life with a disability is a good life, fulfilling life, and this belief is reflected by the UK commitment to equality for everyone. All our laws should reflect that. Abortion law is no different in that respect. So we believe that Regulation 7 of the Abortion Northern Ireland No. 2 Regulation 2020, severe fetal impairment or fatal fetal abnormality as laid down, will perpetuate disability stereotypes. Our opinion has been drawn from the promoted standards around equality, together with our experience as a charity for over 30 years in this field. We're concerned that there was no meaningful consultation with disability groups before Regulation 7 was laid down, where it may be made clear that the exclusion of a disability clause from the regulations would not be in conflict with women's rights. As new laws are laid down, there is an obligation to wrestle with the issues around equality, and in the case of maternity issues, to ensure that we can support women who find themselves pregnant with a baby affected by Down syndrome without coercing them towards abortion, subtly or otherwise. The outcome in Great Britain has shown that the latter often takes place when around 85% of women terminate following a positive screening result. Research shows us that women and their families are happy with their lives, and although we know that with the right focus we can further improve the health outcomes for this group, we do strive so for other social groups. Our charity strives to achieve that aim. Whilst we understand that there are many, many people of goodwill in the health services in the UK, the presence of a disability clause in our abortion law has become problematic, leading to the promotion of abortion for disability, the perpetuation of disability stereotypes, and health inequalities for this group of people, and in a country that chooses to hold equality so dear, we should definitely address this. Thank you, Chair.
Thank you, Dr. Corcoran. And Lynn, would you like to go ahead and make some opening remarks, please?
Sure. Well, thank you, Mr. Chairman, for allowing me to speak here again today, representing the Don't Screen Us Out campaign. I would just like to reiterate that our campaign represents people from a very broad section of society, for those individuals who give birth to babies as teenagers to those who give birth well into their 40s. Consequently, our supporters hold a broad range of views on lots of issues, including things like abortion. However, many of us are united on the matter of disability discrimination. The United Nations Convention on the Rights of People with Disabilities has previously directed the UK to ensure that abortion law doesn't discriminate against disability, nor should abortion law perpetuate stereotypes. That's why we support Paul Given's Severe Fetal Impairment Bill to amend the Abortion Regulations 2020 to remove the ground for an abortion in case of severe fetal impairment. Women who are struggling with the idea of a future with a child with a condition such as Down syndrome deserve emotional support. What they tend to be faced with is the offer of an abortion, which sends out the wrong signals about their future and a life with disability. Down syndrome isn't a tragedy, it's a revelation. To illustrate this, I would like to quote, and I think Liz maybe referred to this, the Royal College of Obs and Gynae recent statement about supporting women in screening. And I'll quote here what they said. They said, some parents whose babies have been identified as having a higher chance of Down syndrome, Edwards syndrome or Patau syndrome, and who have decided to continue with the pregnancy have reported being asked repeatedly if they want further diagnostic tests or an abortion. They report having their decisions challenged and being pressured into changing their minds. That's the end of the quote. We still have a cultural problem with attitudes towards people with conditions such as Down syndrome. A clause in abortion law which promotes disability abortion by its very existence perpetuates the disability stereotypes. It falls short of the standards of equality. Last month, Tommy Jessup, an actor who has Down syndrome, who recently appeared in the popular BBC crime drama Line of Duty, publicly said, "I want to see people with Down syndrome treated equally with others before and after they are born. We are the only group of people in the UK where people try to end our lives before we are born just because we have Down syndrome. This is not fair, it scars our lives." Shortly after Tommy's comment was published in the media, Richard Dawkins, an eminent scientist, talked on RTE about the morality of bringing a child with Down syndrome into the world. He uses the high rates of termination as supporting his uninformed views. Claiming the amount of suffering goes up when a child with Down syndrome is born, all this was plausible to him. He, of course, had no evidence, and he claims that happiness would be increased if a woman had another child without Down syndrome, or even one of the other congenital conditions, including unborn babies that are blind or deaf. The professor said it would be wise and sensible to abort when a baby is found to have a screened for condition. Well, what he said is shocking to many people who understand what a diverse society is. There are many on social media who defend his position. Indeed, the law as it stands in the UK serves his theory well, and I'm sure he's well aware of that. His confidence in making these remarks confirms that much. Last week, Brian Wilson, who was a member of Tony Blair's government until his retirement from politics in 2003, published an opinion piece about Heidi Crowder's efforts to change the law around disability abortion. And I'll quote him, "Does the right to equality," and then in brackets, "and this is not a general debate about abortion, prevail, or is this the one form of prejudice that liberal society is willing to endorse?" End of quote. The crux of the matter is that Down syndrome births in Europe have halved since the introduction of prenatal screening. As Tommy Jessup says, this is a problem for people living with Down syndrome. The Royal College of Obstetrics and Gynecology is also acknowledging the issues that women are facing in pregnancy. We ask you to consider whether the clause around disability abortion is helping minority groups, or if it chiefly serves to perpetuate a view that disability equals suffering. That's all I've got to say at the moment, thanks.
Thank you, Lynn, and thank you both for those presentations. My first question would be to yourself, Elizabeth, around, you had a reference there around the counselling and care pathways, and you said those simply do not exist. What type of counselling and care pathways, and the issue has been raised across a number of sessions, what type of counselling and care pathways would need to be in place to support people better?
So I suppose I want to kind of maybe fill in some gaps, because I was sitting in on that session, and I want to maybe, as a doctor, if a pathway doesn't exist, then doctors would struggle really, to construct the right care package that a patient would need. Very early on, a care pathway around termination was created, and that supports doctors and the health professionals to support these women when they make this choice. But to make a care pathway for women to continue, and we were involved in working with Positive About Down Syndrome and St. George's Hospital, which was mentioned this morning, to make a care pathway for women who have a high chance of carrying a baby with Down syndrome. These pregnancies have higher rates of being affected by stillbirth. They require increased numbers of scans, and psychological support should be provided to help the parents to adjust to this change in the maybe pregnancy that they weren't expecting. So, high quality care for women who would like to continue would undoubtedly help parents to better adjust to the care. The research backs that up, better adjust and be ready to care for the child that they're going to have. I'm sorry, I don't know if I've answered your question 100%.
No, that's so. Even if you could outline for me some of the practical measures in terms of support as a doctor that you think are lacking here and would need to be looked at in terms of reinforcing the support network.
Okay, so what we see is because as soon as a woman is identified to be carrying a child that may be affected by Down syndrome or another condition, straight away she's sort of off-piste, right? She's not on this sort of conveyor belt that the antenatal screening program creates, right? Where you go along like a good patient and have your blood tests and have your scans. So, that creates this sort of dissonance and this stress with the woman not going along. And, often what we see is that these women are offered terminations in the same appointment or very soon after. When they don't want to have a termination, they would like more information. That would be, initially the first thing the person needs. Even before they enter the screening pathway, they need to understand the conditions that are being screened for so that they can make a clear, informed consent about this. Because a lot of times people may continue with the pregnancy anyway, but they don't realize when they're joining the screening pathway that they're going to potentially be reaching a sort of a decision point. So first of all, there needs to be improved dissemination of information around conditions like Down syndrome that needs to be up to date. We've been working with the Fetal Anomaly Screening Program to try and improve their booklets and try and have the most information around Down syndrome, including things like, they're likely to attend mainstream schools, they're likely to live independently with some support. So first of all, improving information at that point at which women decide whether or not they want to go on the antenatal screening program. Down the road, if women choose to be screened and they're shown to be higher chance, again, that information needs to be disseminated again. And we would say allowing people to have contact with organizations like Positive About Down Syndrome, where they can speak to a trained counselor who can help them to get the most up-to-date experience about what life is like living with Down syndrome. So that's one of the things that I would set into contrast with some of the stories you heard this morning from the medical professionals. Is the one thing they don't talk about is what is it like to live? That's the social experience of having this disability, right? Doctors are very good. We memorize lists and we can reel them off. And that's what they do with these situations. And they are doing their duty. They're telling them the chances that the baby might have conditions affecting their heart, but they don't talk about this research involving thousands of people with Down syndrome saying they're happy with their lives. I think that that's extremely important information, which is rarely handed to the woman when they're told their child has Down syndrome. It is handed to them as if it is a death sentence. So I would love to see the handing over of up-to-date information safeguarded within law as well. I think the offer of counseling is really, really important should the woman want to take that up. And indeed, as one of the people mentioned, the fathers as well, they're important support. And often the fathers are used, what would your husband say if you continued this pregnancy? That often does come up as a reason to pressurize women to terminate. I have to disagree with the evidence given this morning that women are not being pressured. This is just simply not the stories we are hearing, and we trust women and the stories that they're reporting to us. What we're seeing is what I like to describe as medical gaslighting. Are you sure you want to continue? What would your family say? What would your children say? Do you really think you could cope with this pregnancy, with this baby? To me, at every appointment, it's discrimination by proxy to the mother, as far as I'm concerned. So, yeah, I think we need a care pathway that is approved by the Royal Colleges, that's improved and is set by NICE and other bodies as a kind of best practice, so that we can hold that against bad practices that are going on and being reported to us as third sector organizations.
Yeah, and I think I think some of the earlier sessions did actually they were equally highlighting the fact that supports and that there aren't a full range of supports in place. But anyway, so the other thing and the final thing that I was like to ask was in relation to, we have heard in previous sessions the indication that there's a possibility that the 24-week limit and the screening issues and all of that could lead to people kind of a clock ticking that would force people into making decisions sooner, or decisions without full information. What's your view of that issue?
This isn't the case that we see. We see that actually it's more the case when people are given the diagnosis, they're offered termination just as a matter of course. This, we're a few years ahead, right? Say if this, you guys can look and see what potentially it could look like for you guys. And what we see is that it's institutionalized, totally routinized, that when you receive a diagnosis of Down syndrome, the natural next step is to be offered a termination. And that has been backed up by the Sharing the News report, which is available online for any of the listeners who want to look that up. That was 1,600 women who have recently given birth. And they reported that they were offered the termination straight away. So in terms of a ticking clock, I think that, I think women, aren't given a cooling off period anyway, as it is in the UK. I think that often when women are given time to cool off, they decide after having time to read up-to-date information that they do want to continue this wanted pregnancy. So, to me, I just don't see that that's an issue. I think that these pregnancies are pregnancies affected by Down syndrome are detected early enough, so these conversations can happen in a timely manner. But I think that there needs to be cooling off periods and time to receive the most up-to-date information. Really, I see that's the biggest time issue.
Okay, well, thank you, and thank you both for attending committee this afternoon, as it has turned out to be. Appreciate you coming along, appreciate the evidence that you have provided us with, both in written format and here this morning, and to wish you both all the very best in the time ahead, and to thank you for your appearance this afternoon. Thank you. Okay, members. So I just need to check with the clerk. Do we have the officials online in relation to the SRs?
Chair, we've one official there for the next one. We've been trying to get the other official, but we can see if they're able to brief.
And what's the situation in relation to, do we have time on these? And if we don't, do we need 5 members? And can we take the briefing now, but then defer the decision back to our next meeting?
I think we certainly could. We've got the members here to make a decision, Chair. We've got
Okay.
we've 5 members, 6 members in the call, so we can take forward these. There is time on one of the SRs that we could reschedule, but one of them is with the extra sitting day today. Sort of puts a wee bit of pressure on the timelines. So I think we're best if we can to get those briefings, but we do have one official there and ready, and we could maybe go ahead and see if we could take that briefing.
Okay, yeah, go ahead. Go ahead with that. So which one is it? Is it 2021 151 or?
Yes, it's
154.
151. So it's 151, Chair. Item 8.
Okay. Okay, so members, we're moving on now to item 8, SR 2021/151. Item 8 is the first of 2 SRs before the committee today. I refer members to the clerk's memo at tab 8.1 of the pack and to the SL5 and statutory rule at tabs 8.2 and 8.3. I can advise members that officials from the department are here to brief the committee on the provisions of the SR. So I'd now like to welcome Ms. Claire Hulbert, who is Tourism Liaison and Policy Branch within the Department of Economy. Claire, can you hear me okay?
Yes, I can. Thank you very much, Mr. Gildernew. Yes. Can you hear me?
And I think it's just yourself at this?
Yes.
Yes, we're hearing you there fine, Claire.
Sorry. I was meant to be joined with my colleague, Mr. McGuigan, but I think with the changing in the times, it'll just be myself, if that's okay.
Yep, that's absolutely fine. So do you want to go ahead, Claire, and brief the committee, and then we can take a few questions? Thank you.
Thank you for your invitation to attend today's meeting of the committee. My name is Claire Hulbert and I work in Tourism Branch. As the committee is aware, the Executive Office is responsible for the revised process which supports the pathway to recovery. This responsibility includes receiving and managing all proposals for change from executive departments, management of the decision-making process, and facilitating consultation with departments on the drafting of amendment regulations if required. This work is supported by a cross-departmental working group which meets weekly and is chaired by the Director of the TEO COVID-19 Task Force team, with membership from all 9 departments, key stakeholders, including local government and PSNI. I am a member of this group. In bringing forward the amendment, colleagues in the Department of Health sought the assistance of the Department for the Economy in providing the detail and support to enable the delivery of this amendment. Today, the committee is considering the statutory rule SR 2021 number 151, which is a 6th amendment to the Health Protection Coronavirus Restrictions Regulations of Northern Ireland 2021. If the Chair is content, I will begin by briefly outlining the context and content of the amendment to the regulation, and then we'll be happy to take any questions. The content of the regulations we are discussing today was set at the executive meeting of the 20th of May, when a number of decisions announced on the 13th of May were reviewed and confirmed. SR 2021 number 130 of the Health Protection Coronavirus Restrictions Regulations Northern Ireland 2021 Amendment number 4 included, inter alia, provision for unlicensed and licensed premises to reopen doors with table service and other mitigations in place from the 24th of May 2021. Table service only was referenced in both the executive paper discussed on the 13th of May and the subsequent written ministerial statement, and in absence of a steer to the contrary, officials were not in a position to take a more nuanced interpretation of the executive position within the making of the regulation. In preparing to reopen, businesses and their representative bodies brought to TAO DFE and civic representatives attention that the regulatory requirement for table service only did not align to their business models, therefore adversely impacting upon the buffet and carvery service familiar in many hospitality outlets, and this generated operational and compliance challenges. It was noted during the lifting of regulations in the summer of 2020 that the legislative position resulted in unlicensed premises not having to operate table service, unlike their counterparts operating licensed premises. Businesses were required to ensure contact details, social distancing and other COVID measures were implemented. Tourism Northern Ireland produced guidance which supplemented executive guidance, and they have recently updated and revised this guidance to ensure additional mitigations in respect of ventilation and face covering requirements were detailed to the sector. TAO and DFE have continued to engage with the hospitality, retail and fast food sectors, all of whom were impacted by this requirement. During the executive meeting of the 27th of May, TAO officials were asked to bring forward, by way of urgent procedure, a paper to address the issue of table service with proposals, including mitigations. TAO sought the support of the Department for Economy on this matter. This led to the Minister for the Economy writing to executive colleagues on the 20th of May, seeking their views on a paper which detailed the issues. The DFE paper noted that any change to regulation would be accompanied by revised guidance, which would detail 1. Updated guidance for operators and fast food and operators within shared areas, which would be multi-outlets that share a seating area in a shopping centre, motorway service areas, and or cafes where food is selected at the counter before taking a seat. Number 2, providers operating buffets and carveries. Number 3, detail the requirement to minimise movement to access and egress the table at which they are seated, select food from a buffet, access toilet facilities, access a smoking area, or leave the premises. And number 4, there will be strictly no seating or service permitted at any bar. On the 3rd of June, the Executive agreed to amend the regulations pertaining to the issues around buffet, carvery and counter ordering through the removal of the table service requirement for cafes and coffee shops. Exemptions were added for restaurant buffets and carveries, taking account of the provision of alcohol in such settings. The amendments to the Health Protection Coronavirus Restriction Regulations Northern Ireland 2021, Amendment Number 6, were made on the 4th of June 2021 at 12:30 p.m. and laid before the Assembly at 2:20 p.m. on the 4th of June. They came into operation with immediate effect. The changes resulted in the permission of food to be ordered other than at table in venues that do not serve alcohol, and the permission of food to be ordered at a buffet or a carvery. In communicating the changes to the businesses impacted, their trade bodies and enforcement authorities and DFE emphasised that it was imperative that while easing the requirements for businesses, the mandatory collection of all customer details as required by regulation and other measures was to be maintained. Queuing must be managed with social distancing, face coverings worn when not seated, as already required in the regulations, hand hygiene observed, enhanced hygiene and cleaning undertaken, and staff safety measures also undertaken. The revision to the regulations applies to businesses previously required to deliver table service only in unlicensed restaurants, cafes and coffee shops, fast food and operators within shared areas, such as seating areas in a shopping centre and motorway service areas. Licensed premises will be required to continue to operate table service for food and drink, with the exception of those operating buffets and or carveries. For carveries and buffets, customers will queue to be served, but food service should be by staff to avoid multiple customer contact with surface and serving utensils. Businesses were encouraged to remind customers to minimise movement to access and egress the table at which they are seated, select food from a buffet, access toilet facilities, and or to access a smoking area or leave the premises. Customers are to be reminded to wear a face covering unless exempt at all other times other than when they are seated. No seating or service is permitted at a bar. In addition, the revised regulations and guidance prepared by TNI was detailed by way of internet hyperlinks online, and these have been detailed to stakeholders. I hope this is useful, and I hope this provides you with a summary of the context in which these two sets of amendment regulations were made and an outline of the content. Thank you for listening, and I'm happy to take any questions that members may have.
Okay, thank you, Claire. I suppose really that does cover it fairly well. I suppose I'm just wondering, has there been any contact from the sectors at all in the aftermath of it in terms of how it's operating in practice, or are there any further tweaks being considered to it? Have you had any feedback on that since?
The feedback we've had, Mr. Gilden, has been positive. The types of businesses that were adversely affected by this requirement, it was always their operating model prior to COVID that table service wasn't a requirement, so they've really just reverted to back to that. But we've also ensured we've a wealth of guidance that's been produced by TNI, and these sectors were engaged in that to make sure that these venues aren't only safe for visitors but for staff themselves, because we've got to be concerned about the safety of all our staff. But very much this amendment and change has been welcomed, because it was very much affecting, businesses that have already greatly suffered because of COVID were then going to be suffering even more.
Okay, and then so that addresses the sector. Is there then any follow-up, and this applies, I suppose, more generally, but just I don't know, in terms of your own information, do you then follow up in terms of testing, like a targeted testing, to see if the measure is having a negative impact in terms of transmission, or does the contact, do you link in with the whole test trace operation to see generally where you put in measures, are those having an impact in the cases?
From an economy point of view, that isn't something that I could answer at the minute, because the testing is the responsibility, as far as I'm aware, of health, but it certainly is something the members of the committee would like that considered. It's something that I could certainly look into.
Yeah, I think we just would have a general interest in tracking, how when various measures are either brought in or relaxed, how it's being monitored in terms of the impact, because I think there's huge learning within that as we move forward. But listen, Claire, there's no other indications from members for questions on that, so I think you've adapted that. So we can thank you for attending, and we will consider our formal consideration now, but thank you for coming along to committee. Thanks.
Thank you very much, and thank you for your time. Thank you. Bye-bye.
Okay, members. Thank you. So members, we'll now move on to our formal consideration of that SR. I can advise members that the SR is subject to the confirmatory resolution procedure, and that the examiner of statutory rules has no comment to make. Have members any further issues they wish to raise in relation to this rule? No, I'm not seeing any indication. So therefore, members, can I ask that we agree formally that the Committee for Health has considered SR 2021/151, the Health Protection, Coronavirus Restrictions, Regulations 2021, Amendment number 6, Regulations 2021, and recommends that it be confirmed by the Assembly. Are we agreed? Yeah, I think we're agreed. Yeah, that's okay, members. And I will then just check back with Clerk. Do we have official on the line on SR 2021/154, Clerk?
We do indeed, Chair.
Okay, so I'd now like to welcome Miss Deborah Sharp, who is International Travel Lead within the Department of Health. Deborah, can you hear me okay?
Yes, I can, Chair. Thank you.
Thank you, Deborah, and you're very welcome this afternoon to our committee, and thank you, and please go ahead and brief the committee on this SR.
Okay, good afternoon, Chair and members, and thank you for the opportunity to come along to the committee and brief you on an SR relating to international travel that has been made since my last update to you all on the 27th of May.
Deborah, just sorry for interrupting, Deborah. We're not seeing you at present. I'm not sure if your camera's on. We're hearing you clear enough, and that's fine if that's all, but we're not seeing you at present.
My camera is showing as being on, so it's not it's not blocked out, as it were. So I don't know why you're not saying me.
Okay, well, listen, don't worry. Go ahead. So long as you're aware. That's okay. Go ahead, Debbie.
Okay, thanks. So the SR that has been made that I'm briefing committee on today is SR 2021 number 154, which came into operation on the 8th of June. And these regulations, as I've said, amend the principal international travel regulations in Northern Ireland by adding Afghanistan, Bahrain, Costa Rica, Egypt, Sri Lanka, Sudan, and Trinidad and Tobago to the red list countries. The regulations also removed Portugal from the green list, ultimately moving it back to amber. They also updated a technical reference to legislation relating to medical devices, which is coded within the context of clinical investigations exemptions in Schedule 4. And they also correct 2 typographical errors, one relating to fixed penalty notices and the amount associated to the offence for not taking a test post-arrival. And the second typographical area is in relation to an incorrect paragraph number referenced in Schedule 7 relating to managed hotel isolation. So I'm happy to answer any questions committee may have.
Okay, well, I suppose my question is really in relation to the ongoing situation with the Delta virus. In relation to this, the travel, are there current? Can you advise any update on what's happening at present in relation to protecting the community from this Delta variant?
Yes. Okay. So in terms of international travel, the post-arrival testing requirements that we have in the legislation, which is day 2 and day 8 for amber arrivals and day 2 for green. So part of that process, the rationale for that was to enable genome sequencing of testing, so that should an international arrival come into Northern Ireland and receive a positive test on arrival, then we would be able to sequence that test and determine which variant has been picked up, and that then ascertains the prevalence of that variant within Northern Ireland. Okay. And in general, the international travel measures are reviewed on an ongoing basis, and you'll be aware of the Global Travel Task Force, the work that's ongoing to continually review these measures, establish if they continue to be proportionate, and seek to explore options in terms of if there are options to ease, then what would that be balanced off against. And also in terms of travel within the CTA, you will be aware that the guidance is now that we ask people to test. Obviously, with the situation in the Delta variant in other regions of the UK and Republic of Ireland, we ask people that come into the country and remain overnight that they take LFD tests, which we provide free of charge. And that is the reason for that is because other regions of the CTA have a higher prevalence of Delta. And this is obviously a mechanism for us to try and delay the increase and import of that variant into Northern Ireland.
Okay, thank you, Deborah. And Paula, go ahead, please.
Sorry, Chair. It was about the COVID passports, the COVID vaccine passports. I'm just wondering, is there any update on that? It's just the constituency queries keep coming in. Thank you.
Hi, Paula. Yes, it is a topical question, and we see lots of queries coming around it. It is something the department are looking at, not personally myself, but I'm aware that it is being looked at by the department. A range of teams are looking at it both from a technical aspect and a policy aspect, and we are working with colleagues in UK government, and I think there's engagement or there will be engagement to ensure there's some sort of mechanism to ensure we are aware of what is applied in the Republic of Ireland too. In terms of timings, I don't understand if there's been anything advised on that, but it is work in progress and it is happening as we speak.
That's fine, thank you.
Okay, thank you. And I don't see any other indications there, Deborah, from members. So I think that is sufficient for now. Thank you for attending and for providing that information to the committee. And we see you again, and all the best. We'll go ahead with our formal consideration. Thank you.
Okay, thanks all. Thank you.
Thank you. Now. Okay, members. So we now move to formal consideration of that SR. I can advise members that the SR is subject to the negative resolution procedure and that the examiner of statutory rules has no issues to raise. Have members any further issues to raise in relation to this SR? No, thank you, members. If not, then can I ask you to agree formally that the Committee for Health has considered SR 2021/154, the Health Protection, Coronavirus, International Travel, Amendment Number 4, Regulations NI 2021, and has no objection to the rule. Are we agreed?
Agreed.
Agreed. Thank you, members. Okay, members, date, time and place of next meeting then. Our next meeting will be on Thursday, 24th of June at 9:30 a.m. via video link. Thank you, members, and please take care. Thank you. Bye.